All right. Thank you, everybody, so much for joining this series of talks. This is Flash Talk Track 1, evaluating the effectiveness and or quality of digital tools. We have a really great lineup of speakers who will be talking today. Each speaker will give a presentation of about 5 minutes, followed by a Q&A for that speaker that will also be about 5 minutes. And then whatever time we have remaining, at the end of all the talks, we'll open it up for another Q&A for all the speakers. So without further ado, I'll turn it over to Dr. Marisa Perera, who is coming to us from Two Chairs.
Hi, everyone. It's nice to see you. If there are any issues with seeing the screen, please let me know. But otherwise, I will assume that you're able to see the slides here. I think I see a nod. Awesome. Thanks, Noah. So hi, everyone. I'm Marisa Perera. I'm very excited to be here to talk with you today about what can happen when you go all in on measurement-based care, or MBC, and outpatient mental health. So I'll just start off by stating that I am employed by Two Chairs and have an equity interest in the company. And let's just talk about MBC for a moment. So you may know that MBC is an evidence-based practice. It is known to improve outcomes and support quality care. Yet, fewer than 1 in 5 providers actually use it consistently in their practice. So why is that? Because implementing MBC is hard, especially at scale. It's time consuming, it adds to provider workload, and it can feel disconnected from the flow of sitting with a client. So a question that we really posed as we thought about the Two Chairs model is, can we use technology to flip this? What if we made it seamless, digitally integrated, and backed by strong clinician understanding and support? So this is what we tested in a real world setting and at scale at Two Chairs. So let me tell you first a little bit about Two Chairs. It's a large national outpatient practice serving adult clients. Typically, folks are seen virtually once a week. There are other ways they can be seen as well. We've got some in-person locations, but that's what's most common, and are seen for varying presentations. Most typically, they fall under anxiety and depressive disorders. In 2023, Two Chairs developed and required clinicians to complete a comprehensive MBC training series that included active coaching and oversight from their clinical supervisor. So here's a quick look at what that looked like mostly from the client view and a little bit of the provider view here. So before each session, morning of, clients are prompted to complete brief digital surveys on common symptoms of depression, anxiety, and therapeutic alliance. And then their responses flow directly into the Two Chairs provider platform in real time. This enables clinical decision support, progress tracking, and data-informed care. So you can see that client view here. You can see the notification on the phone, and what you see in the bottom left image is the client view of symptoms, and on the bottom right image is a clinician view of symptoms from the questionnaires. So we looked at nearly 3,000 adults who began therapy in the first half of 2024 and reported symptoms of depression or anxiety above the threshold on common measures. So you can see some sample characteristics here. For the sake of time, I won't read them all out, but you can take a quick peek there and see. I will highlight the high MBC completion rate, and that suggests that the provider buy-in is really there to really encourage clients to actually complete the MBC and use it. So here's an image of the provider view on the left. This is what it looks like once the data is integrated real time into the visuals. And you can see, I'll just say quickly, just to sort of orient us to that image. So you can see the graph kind of pointing out different data points over time. And on the right, you can see this sort of box popping out with a couple different colors, kind of like the key there. And that is some information about decision support that providers can then kind of use as a suggestion or to sort of determine what may be going on and how to make sense of that data, along with their personal judgment. And so to evaluate impact on if and how much better clients get that is clinically meaningful, we looked at outcomes at session 12, or the last available session between 4 and 11 if someone ended treatment earlier. And we focused on 3 key metrics and concepts. So the first one is recovery, meaning symptom scores drop below the typical clinical threshold for the PHQ and GAD of 10. Reliable improvement is a meaningful drop in symptoms, and remission is in a range that's considered minimal or no symptoms. So we looked at these 3 concepts, and here's a little bit of how that ended up looking. So among clients, again, who started with that sort of elevated at 10 or more of their score on the PHQ or GAD, which are PHQ measures depressive symptoms, GAD measures anxious symptoms, we see that from the sort of baseline score to the outcome, that there's about a 5-point drop on average looking at each of these. And then when we look at recovery, over half are meeting that recovery milestone, and same, but over half meeting that reliably improved. So that improvement that is a meaningful amount versus like an increase in 1 point here, and maybe it goes back down and then goes back up again. So a more reliable improvement. And you see that there's a bit of a bump for the anxiety symptoms compared to the depression symptoms. They're slightly higher there, 55 versus 61, 53 versus 64. And about a fifth are meeting for remission, where they're in that range considered minimal or non-clinical. And the effect sizes were strong. So the image on the bottom here shows just a little graph of kind of how these numbers looked over time. So what did we learn? With the right tools, training, and support, MBC can drive real clinical impact at scale. It's not a fix-all. We focused on depression and anxiety, and it required high clinician engagement with the way we approach this. And long-term outcomes analysis will be done. But what we know right now is that the early results are promising. When MBC becomes part of routine care, we see outcomes improve, and it gives us a bit of a playbook for a way to make this happen in the real world. So with that, thank you for hanging with me and learning a little bit about our approach to MBC. Happy to answer questions if we have time for that, Noah.
Yeah, we have a few minutes for questions. So thank you so much. Because we have so many folks who have joined for this talk, if you want to ask a question, click the react button and then click the raise hand button just so that we all don't unmute at once. Alternatively, if you don't want to talk, you can post your question in the chat. But the floor is open for questions.
Also, Noah, I cannot see the chat, so if a question pops in there, I would very much appreciate if you let me know. Thank you.
Yeah, will do. I can kick off the questions. I'm curious, Dr. Perera, what you see as like the biggest barrier to clinicians implementing like outcome monitoring in their clinical practice?
Yeah, it's a great question. I think that maybe a couple of things. So one piece of MBC is like just getting into the flow of it. Like it's just a different, like your workflow is a little bit different. You kind of become more open to using data to inform your care. And that right there could be a bit of a difference than how people have been typically practicing. Therapy is seen as a very human, it's very based on a human connection. And so the moment we bring in data in like a consistent way, when we know that the symptoms are never going to be the way these measures ask things are never going to be a one-to-one map on like a unique client symptoms. And so I think that is a bit of like a, I don't know, attitude barrier, if you will, from an actual like clinician user end. And then there are actual logistical like pieces of it. If we're really talking about like very personalized MBC care, you might use a different set of measures with one client than another. There's a lot of burden that goes into that from a provider perspective. And when you've got a bunch of clients you're seeing, you don't have a lot of time in between sessions to like shift mentally, think about these different measures, think about the data, remember the case and how the data fits in. So I do think there's a lot here around like the clinical sort of rationale, benefit, experience of it.
Sure. We have a question in the chat from Sarah, who said, "Great talk. What boosted adherence rates on the member/patient side? What got more patients to complete their assessments before sessions?"
Yeah, it's a great question. We really believe that leaning into that intensive MBC training that we did in 2023 was a really key part of that. It was a couple modules. It was not like a one-time training. It was over the course of a couple months. It was kind of layered, like first sort of understand the clinical rationale, now begin to maybe a couple months later begin to think about how you actually use it in practice, did some actual like practice sessions, some skills assessments. So it was like it was a pretty involved process. And we really do believe that that helped bring folks from like, I don't really know what MBC is, or I don't really know if I see the value in it, to, oh, okay, I'm testing it. I'm talking about it with my supervisor. I've got some examples. So we really think that was a big part of it. People really understanding how it can help them in their care.
Great. Thank you so much. For the sake of time, we'll now turn it over to our next speaker. So next we have Dr. Caitlin Stamatis, who is coming to us from Bruin Health.
Thanks, Noah. Let me share my screen here. Okay. Can y'all see this? Good.
Yes.
Amazing. Cool.
There is a kind of a window that says continue to share using, continue to share this PowerPoint window using SharePlay.
I don't know how to click. Oh, there we go. Okay, great.
Great.
All right, thank you. Okay, so hi everyone. Thank you so much for being here. Sorry about the technical difficulties. I'm Caitlin Stamatis, and quick disclosures. So I'm actually an employee of Otsuka. They pay my salary, and I want to emphasize that all views expressed here are my own. And I am excited to share a collaborative effort from the SDMH Industry Special Interest Group. This is a framework for how we generate and communicate about evidence for digital mental health interventions in depression and anxiety. And so I'll start by telling you how this got started. So at our quarterly SDMH Industry SIG meeting, people from different digital health companies and academics gather. And I think we really quickly realized that we share a lot of the same frustrations, right? So among them, we care deeply about evidence quality. We see real challenges with how we communicate science, and frankly, want to hold ourselves and our companies accountable. So a few years back, two authors on this talk, Doctors Valerie Forman-Hoffman and Ben Nelson, had put together a coalition to start to change this. And as a SIG, we saw that this was really an industry-wide challenge, right? We may be competitors on the face of things, but no one company is going to fix this alone. So our goal alongside academic and government partners was to create guidelines to, again, hold ourselves accountable to producing evidence that could help providers, payers, patients just better evaluate the quality of digital tools. And just backing up a little bit to why this matters. So you all know this, right? One in five adults report depressive or anxiety symptoms. Less than half of people with depression, less than 30% of people with anxiety receive care. And we know that our companies are putting out solutions with potential, but really we see core problems, I think, that undermine confidence in our field. So first, with some exceptions, I think especially for regulated products, companies are using vastly different outcome measures, study designs, reporting methods, makes it really hard to compare solutions. There are issues with inflated effect sizes, with missing data handling, lack of rigorous controls. Studies often aren't reporting on how they did or didn't include the diverse populations we aim to serve. And of course, these are not unique challenges to digital health, but I think they're super important given the increased skepticism that hinders adoption, right? So my perspective is don't give providers, patients, payers another reason to doubt with lower quality evidence. And just to dive in and briefly on the science communication piece, these are actually real examples. They're anonymized from digital mental health company websites, like we de-identified them. On the left, we'll see, something like a broad construct like anxiety decreasing over time, right? How is it measured? Was it the GAD-7, a clinical interview? There's no sample size, no confidence interval. We'll see quotes, right, that come from studies that actually weren't done by the company, but are presented in a way that they seem to be about the company or product. Or taking this image, maybe we have stats on, oh, this tool increases quality of life, but if we go into the cited paper, well, maybe it's a marginally significant increase in a single quality of life subscale in 20 veterans, right? So I think misleading communication. And I'll note that it is harder for this to happen with regulated products, right? Any marketing for digital therapeutics goes through a ton of scrutiny because FDA will penalize for misrepresentations of data. And really with these guidelines, we want to model that type of fidelity to evidence earlier for wellness products for digital therapeutics alike. So turning to the guidelines, there are sort of two main components. First, we have scientific publication standards. I won't walk through these in detail, but we focus on kind of one, consistency of outcomes, right? How do we define MCID, response, et cetera? And two, statistical consistency, especially for different trial types, recognizing many companies can't or aren't doing RCTs. So what do standards look like for real world evidence studies? Can we introduce things like synthetic control groups, historical comparisons to increase rigor? We're publishing this along with a checklist for researchers. Here are just some kind of snapshots of that. So a checklist around outcomes, around how do we define engagement, right, in evidence-based ways, statistical modeling best practices. Second pillar of the guidelines is around this scientific communication, since so much of how we learn about digital mental health interventions, as we know, is not through scientific pubs, but through things like marketing materials, white papers, investor presentations. So emphasizing that scientific translation too. So to wrap this up, our goal with these standards is to create competition based on actual effectiveness of digital tools, not kind of sophistication of marketing. But as a author group, we are really still struggling with this reality that so many researchers don't have the resources for anything close to an RCT in industry. So how do we meet digital health developers where they are when it comes to promoting rigor and transparency for a range of study designs? So in any case, kind of high level overview, but I think to bring it to a close, what really started as conversations as the industry SIG has grown into a framework that we're excited about. We're not kind of waiting for regulation to catch up. We know we're part of the companies producing this evidence and want to shape that change. So I just want to say a quick thank you, especially to Val, Ben, and Liz, to all of our industry academic and policy co-authors. Thank you all for listening. Would love this group, the audience's input on this. And if you're interested in joining the SDMH Industry SIG, please do reach out to me or Trina Histon. So thank you so much.
Thanks so much. I'll open it up for questions, comments, either from Zoom folks in the chat. Yeah. I'm happy to kick us off again with a question. Oh, great. Kiefer, also apologies if I mispronounce anyone's name. The person who has their hand up, feel free to unmute and ask your question.
Yeah, thank you. Sorry, I am have some difficult there we go. Qualitative, measurable differences. I'm just wondering how much discussion you have over the measurement tools themselves in terms of the GAD, the PHQ, where I feel like these things are kind of been co-opted from, pencil and paper over long periods of time to now be done frequently. We're talking about, a wide range, they're kind of made for clinical populations that are definitely meeting diagnostic threshold. That's kind of what they're for. And so I'm just wondering, whether you're also thinking transdiagnostically, mechanistically, as I see the appeal of going with these measures for expediency, but just wondering if you are considering other measurement kind of approaches other than kind of DSM-centric diagnostic tools.
Such a great question. I mean, in my dream world, every digital health tool would, right, like we would be using a purely dimensional approach to understanding how these are working, and we would be getting at mechanistic factors like rumination and anhedonia, right, alongside clinical symptoms, and be looking at quality of life. I think for where we are right now, in terms of the kind of capacities, like pragmatically with budgets on research teams doing these studies, if we could even get people to consistently throw in a PHQ-4, like that would be a huge win from a consistency perspective and really just being able kind of comparability of evidence. So I guess high level, like we have not really been thinking about that as it relates to this particular initiative. And it's something that as the field evolves, I feel like is going to be really integral, right, to how we understand efficacy and effectiveness of these tools.
Great. And we have a question in the chat.
Thanks.
Yeah, thank you. What do you recommend for comparisons when evaluating digital therapeutics?
So that's an interesting question. I think in that with digital therapeutics, I think, you know, there's already a certain layer of scrutiny that they have gone through, because in order to be labeled a digital therapeutic and make kind of marketing claims around being a treatment for a specific disease state or indication, they have to have had a, you know, typically one or more pivotal phase 3 trials that are reviewed, data that they're submitting to the FDA showing that they're safe and effective. Pretty similar to the way that there would be scrutiny around a drug trial. So I think if something is a digital therapeutic, it's generally safe to assume, right, with always be cautious, always look into the data, always do your homework, but to assume that there has been a pre-vetting of sorts in a way that many digital tools out there that are wellness products or kind of supporting health broadly are not regulated in the same way, right? And so I think there's a need for more of a critical eye. And I think what is a challenge right now with digital therapeutics is because the whole idea that an app would go through a similar regulatory process to a pill, right, feels so foreign. It's so hard to wrap your head around, I think, for specialists, for you know, let alone like the average consumer. It is something that's very hard from a science communication perspective of how do you communicate the value prop of that kind of the difference between a digital therapeutic and a standard wellness app. I think that's something that as a field we're still trying to figure out.
All right, thank you so much, Dr. Stamatis. I'm going to turn it over now to our next speaker, Claire Beatty. Feel free to share a screen on your presentation.
Great. All right, I hope everyone can see that. So today I'm going to be presenting findings from NoCD on 2 large-scale studies where we examined virtual habit reversal training. Just to disclose up front, I am an independent contractor at NoCD and I receive compensation from them. So we're looking right now in these 2 studies at tic disorders as well as body-focused repetitive behavior. So trichotillomania, which is hair pulling, and excoriation disorder, which is skin picking. And so collectively, these conditions really affect up to 10% of the population and can significantly impair quality of life across many domains. But there is a pretty massive treatment access crisis specifically with these disorders because they're specialized disorders that require specialized training in the gold standard behavioral treatment, which is habit reversal training. So just to put this crisis in perspective, about 65% of people report that with hair pulling, report that they've never sought out treatment. And that's largely due to what I just mentioned, which is provider shortages and geographic barriers. So habit reversal training has been shown to be effective in in-person studies. It involves awareness training to help patients recognize urges and behaviors, competing response training where patients develop incompatible responses, and then also stimulus control to modify environmental triggers. And so there's really limited research that looks at whether virtual delivery can address some of these access barriers, especially across the whole developmental spectrum. So trick, excoriation, and tics mainly start during childhood to adolescence. So it's really important that we kind of step in early. In these two studies, we conducted retrospective observational analyses of clinical data from NoCD's telehealth platform. It was across the years of 2021 to 2025. Our total sample was about 1,238 patients. So we had the Tics study where we had a predominantly youth sample of about 167 patients, and then the trick and excoriation disorder study was about 1,071 patients. NoCD treatment is 60-minute video sessions, and therapists were trained to deliver the core HRT components. Patients also had access to messaging through the app where they could talk to their therapists. Of course, patients utilize this differently and to different extents. And they also had access to mobile symptom tracking on their devices and support groups on the app. So both of these observational studies, we had a bit of different assessment approaches. So for the Tics study, we used outcomes at session 7, 14, and then at follow-up, which was the patient's final session. And then for BFRBs, we used calendar-based time points. So week 5 to 7, week 14 to 16, and then long-term follow-up through week 52. We use last observation carried forward for missing assessment, so pretty conservative approach. And we use validated measures like the parent tic, adult tic questionnaire, and the parent tic questionnaire for kids. And then for BFRBs, we use the repetitive body focused behavior scale. And similar to the guidelines that Caitlin outlined, we did use clinical thresholds established in the literature to determine clinically meaningful treatment response. And our analyses were all linear mixed models. So just looking at the results here. So with the BFRB findings, the box plots on the bottom here show that show our RB-FBS scores for hair pulling and skin picking patients from baseline all the way through that week 52 time point. And so you'll see if you look, at the bottom of the slide that the data shows this consistent downward trend in the symptom severity. So by our primary endpoint, which was week 14 to 16, when patients had completed approximately 7 to 8 treatment sessions, there were large effect sizes of about 1.01 for trick and 1.16 for excoriation. As you'll see, the sample sizes decreased naturally by week 52, but for those who did stay in, they continued to improve. And for clinical response, we use an established 35% reduction threshold, and 44 to 49% of patients achieved that improvement, which is pretty comparable and exceeds some in-person trials of HRT. So for tic disorders, these box plots show ATQ and PTQ from baseline through session 14 and final session. On average, they were completing about 15 sessions over about 18 weeks. And you'll see here on the bottom that the PTQ scores for youth showed this steady downward trend. Adults started off with slightly more severe symptom severity, decreased a little less dramatically, but both achieved moderate to large effect sizes, 0.53 for youth and slightly more moderate for adults at 0.36. In terms of clinical response, we use a pretty stringent 55% reduction threshold, and 36% of the whole sample achieved that response. So, across these two observational studies, right, they're retrospective studies. So, that's a big limitation. There's no control group, so we can't establish causation. But the results really do show that patients across the whole developmental spectrum, right, the youngest patients in some of these cases were about 4 to 5 years old, show meaningful improvement through virtual delivery. It's important to note that NoCDs offers a pretty comprehensive platform where it's not just these virtual sessions, but also messaging, support through the app, community boards, and support groups. And And the effect sizes really did match or exceed traditional in-person treatment. The BFRP paper is currently under review, and the Tics paper is about to be submitted. And I have shared the preprint for the BFRB paper here and hoping it's published pretty soon. Thanks for listening and happy to answer any questions.
Okay, thank you so much. We'll start with a question that was posted in the chat. How did you determine the threshold for clinical response?
Yes, so the clinical response threshold for tics, starting with tics, so we use the parent tic questionnaire and the adult tic questionnaire where there's not established clinical cutoffs, but the Yale tic severity, I can't remember the exact name of it, the YGTSS, their established cutoff is 55% clinical reduction on symptoms and 10-point reduction on the scale. So we used that one. And same thing for the repetitive body focused behavior scale. There aren't established cutoffs necessarily, so that's a limitation. But the 35% reduction has been documented in other studies using validated scales for trick and excoriation. So we kind of mirrored those.
Any other questions that folks have or thoughts? I can ask a question for my own curiosity because we still have maybe a minute left in your time slot. Are there any folks for whom you think kind of a virtual option for habit reversal training might not be a good fit, and for whom kind of they might benefit more from in person?
Yeah, that's a great question and something that I think we're hoping to dig into a little bit more in future papers. Just from my, anecdotal experience, I'm thinking that we based on like the diamond and just severity benchmarks on those validated measures, we didn't have as many folks in the super severe range, and I think there's a reason for that. I think virtual delivery of HRT can be effective, especially for people who are, more mild to moderate, because you have them in their natural environment virtually, and, you get to see how they're operating. A lot of these people had comorbid OCD in particular, which you can see if you download the preprint. But I think, that for those people who are more severe, I think we're kind of missing information on how they would respond. And I think those people probably might do better with in person.
Great. Thank you so much for the wonderful presentation. I'll turn it over now to our final speaker, who is Bryn Lofness from University of Vermont.
Great. Thank you so much. I'm excited to be here. So again, my name is Bryn Lofness. I'm here on behalf of my team at both University of Vermont at Vermont Complex Systems Institute, as well as Wake Forest Medical Center. I have an amazing interdisciplinary team, and unfortunately, I'm the only one here presenting us, but I want to shout them out so their names are there at the bottom. So today I'm going to be talking a little bit about what my team does together and a little bit about our most recent pilot study. And what our team does is we use wearable sensors, both in clinic in structured environments, as well as at the home, to understand more about what we might understand about early childhood mental health, symptomology, as well as how they respond to stress or threat or reward or play in ways that we might be able to give voice to them in screening processes that often rely a lot on caregiver screening and report. So jumping into it, I would like to disclose right off the bat, I am the co-founder and CEO of BioBee, which is an early stage spinout from both Wake Forest and Vermont Complex Systems Institute, with some of my faculty member colleagues and clinical partners trying to bring these screening and intervention tools to real world environments and outside of the lab. Great. So why does this work matter? I don't really need to set the scene too much of this. I think a lot of us here know that we have some really big gaps within the childhood mental health space in terms of intervening in a timely manner, but also making sure we're addressing the problems as early as we possibly can. And that's what my team is really interested in doing, and that's why we focus more on kiddos under the age of 10. So really it's those kiddos that can't usually report on their own mental health status, and we really rely on caregiver report. And that's where objective monitoring might give us additional insights or different ways to measure responses or even measure effectiveness of treatments. Just moving forward from here. So this particular study, this was just conducted in the last 2 years. This study has about 104 children in it between the ages of 4 and 8. And during this study, we recruited kids directly from the waitlist at Vermont Medical Center of parents seeking follow-up care and a gold standard diagnosis. We had a clinical psychologist on our team that conducted the case ads with all of the parents, while we introduced the child to a 10-minute assessment that included 3 different tasks. During those tasks, we look at the child's responses, whether they're responding to giving a speech for 3 minutes or playing with bubbles for 3 minutes. And we understand a little bit more on what we can observe, but also what's maybe happening underneath the hood. And that happens with maybe their heart rate or their temperature changing or how they're moving. And I'll get into that in just a moment. And so in all of these different places that we're measuring across the body in this 10 minutes, in these low-cost sensors that just either attach to their wrist or are adhered onto the skin, we use consumer-grade devices to understand what's currently on the market. There isn't a ton of research on early childhood wearables, so we also try and contribute to that space to understand how these consumer wearables might be used in clinical practice or even in research-grade practice. And we understand through different computational techniques which modalities might yield the most interesting or informative features, i.e., is it the heart rate at a certain component of the speech task, or is it how they're moving and the amount of their movement during the bubbles task that's relating most to their gold standard diagnosis? And we use that target from that parent's interview and also what that parent observes to understand more about what patterns we might uncover. Okay, this is an example of some really interesting kind of preliminary graphs we had from this study where we're looking at specifically when are features important, when are specific modalities important. And this gradient you see across this figure for each of these different subgraphs is when there are certain features that are more important. So for this third row down, you can see heart rate becoming less and less important through the speech task for this subset of kiddos. And what that tells us is the beginning of the task, right when they're told to give a speech, that's when we're seeing the most discriminative responses. And what that tells us in future studies is to look more at the speech task, to understand more about that immediate stress response. And is it the blunted heart rate? Is it that they have a heightened galvanic skin response? And how can those early measures give us more insights on how they're responding and how they're feeling that they may not be able to articulate? Additional things that are really interesting about this study and other studies we've done, this was the third in a set of pilots of this assessment. And what we found was not only did these results or these models find additional children and yield additional accuracy, it complemented parent reports by finding different children that weren't typically uncovered in parent report screening through the CBCL, which is what we used in this particular study, which we found really interesting and tells us as we continue to develop these models and learn more in the research space where we're doing this with our clinical partners, there's a lot more we can learn about how behavioral tasks can yield insights using wearables into different ways to give voice to young children during screening. We have a lot of years before this can be ever used in actual clinical practice, and that's why we lay the groundwork now in research settings to understand and learn more about behavioral responses in young children, which is a very new field. So if you have any questions, thank you so much for your time. You can scan this QR code to access our publications, and you can access information on BioBee or reach out to our team for how we're using wearables in structured clinical settings like I've described or in the home.
Great, thank you so much. All right, we'll open the floor for questions. Yes, Andrew, go ahead and ask your question.
when you're thinking about how this will be used in the future, once there like is that foundation, do you feel like clinicians are more excited about the diagnostics aspect or like the treatment response, like tracking response to treatment aspects?
Yeah, that's a great question, Andrew. We actually did a large-scale customer discovery journey to learn more about how clinicians might perceive a new kind of screening like this. And the big things we learned from that study is, one, wearables are new in this space. There's a lot of apprehension in to use this as a screening. We'd never use it as a diagnostic. It's always to keep a parent and clinician in the loop. And while there was interest there, using it as a way to measure treatment response or to pair it with other kinds of interventions or treatments was of interest. And so I think beyond getting past, wow, this is data, this is AI, this is scary, and getting into how this can be used in clinical practice, I think we have a lot to learn about what's exciting and what's possible, but definitely some interesting perspectives there. Great question. Yeah, Sharon?
Thanks for your talk. It was super interesting. My question comes from, I have some, background and experience doing neurophys, so EEG, in really, same age range. And one of the things that we encountered a lot is that I think something that you've said repeatedly is that we just don't have a lot of data on it. And so when it came to trying to figure out like what just meaningful indices and like how to understand the numbers, can you just speak a little bit more about how you and your team are doing that?
Yeah, it's my team talks about this a lot in terms of it's exciting and it's fun, but it's also so frustrating sometimes because it would be great to be able to turn more to the literature to say, what has been done? What is the typical reactivity? But that's why we're excited to lay the groundwork to do that kind of exploration and to publish a lot of explorative studies and to say, here are the responses we're seeing. We see they relate in XYZ ways. And hopefully over time, we'll build up that infrastructure of understanding what does objective measurements look like in the home? What does a normal amount of sleep, a normal amount of activity, a normal amount of whatever, your heart rate changing when someone tells you to give a speech, all of that paired together, what that can give us? I think we have a lot to learn. So that's a great question, Sharon. And really cool work. I'd be curious to hear more about that.
All right, one final question for you, Bryn, from the chat. Do you face or anticipate any privacy concerns or concerns around data sharing from caregivers of these kids?
Yes, that's a great question. My team has thought about this a lot. We actually did a whole paper about it on the ethical concerns of using digital phenotyping technologies for this type of work. So I think there's a lot of stakeholders that one needs to consider. A parent wants access to this information, but really a clinician needs to stay in the loop. They need to understand what a behavioral response is. So there's a lot of education that needs to be done. There's a lot of regulations that need to be followed. And so that's a larger conversation about ethics and privacy, but definitely very important in this space. You're dealing with a very vulnerable population. You want to give them voice, but you want to make sure you're doing it in a safe way. Great question.
Great. Thank you so much, Bryn, and thank you again to all the wonderful speakers that we had today. We'll open up for our last 5 minutes. Questions that people have for the full panel or if they want to follow up with a specific speaker. And just as a note, Dr. Perera had to leave early, so she is not here for the... Oh, no, sorry, you're still here. You're just camera off.
Yes, I'm here for 5 more minutes. Thank
Great,
you.
and that's all we have left. So just going to open the floor for more questions.
Can I ask Bryn a question? I would love, this might be too tech heavy, but the quick graph that you showed up of, or the CBC versus the wearables versus diagnosis, was diagnosis from the case ads or it was quick.
Yes, it was super quick. The flash talk format, I love it, but it is challenging. It is challenging. So yes, what I was showing there is we were showing the proportion of kiddos that had been identified through the CBCL, so just purely through parent report. And then we were comparing that to how many kiddos were identified through our objective models. And that was trained off of the KSADs. And so that it was clinical consensus. So there is a little bit of overlap there. But in being able to identify different subsets of children, that's where we report that there's overlap in that clinical consensus between the CBCL and KSADs, but that's how we came to those. That's a great question, Rachel. And yes, it is so hard to do those graphs quickly.
I have a question for Dr. Stamatis. When will those guidelines be available for folks to look at, and where will they be published? Because they seem very helpful.
Thanks. Yeah, hopefully soon. It's something that we're all kind of working on outside of our 9 to 5. So it's been tricky to like get it over the finish line. But right now what we're doing is kind of working with some of our academic and government partners to incorporate feedback, make sure this really reflects a multidisciplinary perspective, and then we'll be submitting for publication, hoping to publish it in a scientific journal. So we'll definitely let you know when it's published. And I did see, Sarah, you had a question in the chat on kind of how this relates to the Peterson Institute or the Peterson report, which I think is a really important one, and also just a future where a company could say that they met these standards. Like, yes, would love that. I think, we're thinking about kind of could we anchor this onto, I think, practically like tiered evidence standards, right? So borrowing from frameworks like NICE in the UK, or like the APA app evaluation model, right? Thinking about how do we take those and kind of tailor them to the realities of digital mental health. And I think I would love to see a future where there's some kind of stamp of approval, right? Similar to what we see with kind of DTA for specific to digital therapeutics, or like the LEED stamp on buildings, right? Like something equivalent to just facilitate that decision making of like someone has pre-vetted this, right? Even if it's not a digital therapeutic. And then on the Peterson front, I'll just say that I feel like, they made a fairly kind of strong statement in defining what they consider sufficient evidence around like clear preference for RCTs, right? Like kind of comparative effectiveness versus standard care, focusing on not just engagement, but like the actual ROI, which we expected. I think all of that is great. And I think there's also just this question of how do we integrate that rigor with some of the maybe a more developmentally informed perspective, where products can be held to different standards for kind of their stage and the strength of claims they're making.
Great. And with that, we're just about at time. So how about we wrap up there? Thank you again to our wonderful speakers, and to everyone for joining this talk.